Hi everybody, so I've been asked to give you a short talk about the role of an orthopaedic nurse practitioner within a multidisciplinary team, which I am part of here at the Queen Elizabeth Hospital. And my role as an orthopaedic nurse practitioner is in arthroplasty. My name's Lesley Thomas. So just a bit of a background about nurse practitioners in Australia and overseas. The role has been established for over 30 years ago in the US, Canada and the UK. In Australia it's still considered relatively recent. The first endorsed nurse practitioner role was in New South Wales in 2001, and that was in a remote area. The title of nurse practitioner is protected under national law. Only those endorsed by APRA can use the title. So back in 2016, when they looked at the current workforce of nurse practitioners in Australia, there were 1,417 registered, average age of about 49, so we are an ageing population. Obviously more females than males, and 49% or almost half of the workforce was located in Queensland and New South Wales. The Northern Territory has the largest number per estimated residential population, though, given its size at almost 10% per 100,000. So the first orthopaedic nurse practitioner was endorsed here in Australia was Cheryl Kimber, who some of you may be familiar with, and she works at Flinders Medical Centre, and that was in 2005. Currently there are 9 endorsed nurse practitioners working in the areas of fragility fracture, arthroplasty, orthogeriatric trauma, trauma including paediatrics, fracture, non-surgical in outpatient settings, rehab, bone and soft tissue tumour, surgical ortho, spinal neurology, and general ortho, and those last two are in the private sector. So the role at the Queen Elizabeth. So obviously you don't just come by one of these roles, you have to identify a gap in the service. So we had to establish the need for it. So back in 2007, the health plan that was for 2007 to 2016 estimated that 1 in 6 people, or 15% of South Australia's population, are aged 65 and over. We know the AOA National Joint Registry predicts that the demand for hip and knee arthroplasty surgeries will double over the next 10 years. Long wait times for both assessment and surgery are associated with adverse outcomes, so the implementation of a nurse practitioner role was thought to result in improved patient outcomes and efficiencies within service delivery. And that was part of an ADAM project, which was part of the Orthopaedic Clinical Network, which was established back in about 2008, I think it was. So what the orthopaedic nurse practitioner arthroplasty role provides. So I deliver advanced level care of nursing management and clinical support to patients with osteoarthritis of the hip or knee, waiting and undergoing arthroplasty surgery throughout the continuum of care. So essentially I see them from the minute they come into the service, be it through the outpatient setting, right through until they are discharged following their joint replacement. I practice autonomously, but as part of a collaboration with patients, their family and carers, and other interdisciplinary healthcare professionals. I use advanced assessment skills to diagnose, develop and support inclusive management plans for these patients. My target population is case management of patients with OA of the hip and knee that are above the age of 18. They're referred to the outpatient department with a provisional diagnosis of OA of the hip and knee. They may be on the waiting list for their hip and knee surgery. They may be undergoing their hip and knee surgery, primary or revision, or they may have previously undergone arthroplasty surgery, or they could be rehabilitating from arthroplasty surgery, or they may present back to the hospital with a complication due to this surgery. Excluded are people that obviously are under the age of 18, because we don't have those patients here at the Queen Elizabeth. Acute orthopaedic trauma and injury, other elective orthopaedic procedures, and chronic orthopaedic disorders or disabilities. My referral basis comes from those patients who attend the ARAC, which is the Arthroplasty Referral Assessment Clinic, and then go on to be placed onto the orthopaedic waiting list. During or following an admission to the QEH for hip or knee arthroplasty surgery, so I become the point of contact for a lot of these patients on discharge for any sort of questions or concerns that they may have following their surgery, or even those that are still waiting for their surgery. Orthopaedic outpatients at the Queen Elizabeth, other clinical services at the QEH. Occasionally I will get the phone calls from the GP practices. They may be reviewing a patient who's recently had surgery and they have concerns about their wound, or they may be somebody that has OA of the hip and knee and they're concerned about how long it's taking them to get into the service to seek review. rural and community health services, so lots of phone calls from patients that have undergone the surgery in the rural sector once they go home, and other institutions, not so much really nowadays, but occasionally from Hampstead if they've gone there for rehabilitation, and obviously lots of phone calls from patients and families themselves. The role includes the ordering of specific diagnostic tests following comprehensive physical assessment. So that allows me to order for the pre-op patients the blood tests, x-rays, but I can't order that on behalf of myself. I have to order that through a backdoor version because our x-ray department here is I don't have an MBS number, so I'm not allowed to order my own x-rays, but I can do that on behalf of one of my medical colleagues, and other tests that are described there. And obviously, if I do the ordering, then it's my responsibility to do the follow-up of those results and discussing those with the patient's surgeon. I am allowed to prescribe. I do have what's called a P list that clearly outlines each individual medication that I've been authorised to prescribe. It undertakes to utilise principles prescribed at the National Medicine Policy to ensure appropriate and safe use. It requires development of activities audits to ensure principles that I adhere to. And because I am listed as the ability to prescribe on my registration, it means that I have to do an extra 10 CPD points per year to meet those APRA guidelines for ongoing authorisation. There's just an example of my P list. So as you can imagine, it's really around pain relief, be that simple or opioids, and obviously reversal of the opioid medication. Also, as you would imagine, anticoagulations and antibiotics. Non-pharmacological management that I try and encourage with the patients while they may be on the waiting list for surgery or I've seen them in ARAC, lots of education. So it gives them an understanding of their disease process, its progress and the rationale for and implications for managing their condition. So for example, lots of education around lifestyle changes and increasing their physical activity where possible. Physical therapy, so referral into our physiotherapy department. They run lots of programs for hip and knee patients, be that preoperatively or post-operatively. Diet, so we actually do have a orthopaedic bariatric pathway to make sure that our patients are safe to proceed to surgery, so we don't accept BMIs above 40, and if we do encounter those patients, then we do have a referral pathway to a primary health nurse that will help them with those lifestyle changes. And obviously that will include, she will do a lot of counselling if they are smokers around ceasing smoking as well. So I guess the question is, has this role made a difference? So as you can well imagine, I have to justify my role on a continual basis with stats. So since its first inception in 2010, when the length of stay for hip and knees was sitting just over 7 days, we have reduced it only a couple of years ago down to the 5-day mark, and now we currently aim for 3 to 4 days in hospital. We did do a patient satisfaction survey when we first implemented the role to see if it did make a difference, and by the results there you can see the majority of patients did agree that having that one continuity of healthcare provider from start to finish did make a difference for them. And initially the ARAC clinic certainly did decrease the time for outpatient appointments, but unfortunately due to changes in the service and our ability to have consistent clinics, it's now blown out again to about, I think the last time we looked at average wait time was just over a year for an appointment for ARAC. How's it evolving? Well, we're always looking at ways to improve the service, and obviously my scope of practice, and I undergo a credentialing process every year through Callan, so that makes you review your current scope and make any adjustments that are necessary. And obviously we make changes to clinical practice based on advances in evidence that impact on improved outcomes for patients. So back in 2011 we implemented an enhanced recovery a joint replacement pathway for those patients, and the picture on the left-hand side of the screen there is our first patient that went through that pathway, and that's her a couple of hours later getting up and going for a walk with the physio. We obviously, as I've mentioned, implemented the orthobariatric pathway to address lifestyle changes prior to surgery. We also have a pre-op anemia pathway where I work closely with one of the haematologist consultants here at the hospital, reviewing all blood test results. So what happens is a patient's placed onto the orthopaedic waiting list. I will provide them with a letter to take to their GP for routine blood testing, and then she assesses those results along with myself, and if we identify any issues around iron deficiency or anemia, then we try and address them while they're still in that waiting phase. And that has certainly proved to be very productive in the fact that we don't defer patients now at the pre-admission appointment due to the discovery of low iron stores, etc. We've got plenty of time to address those issues. And just recently we introduced skateboards for patients to help with their range after total knee replacements as part of their post-op exercises, which incidentally appear to drop our length of stay by almost 1 day. You get lots of opportunities in a senior role, nursing role like this to make a difference. So I was fortunate enough, as part of my membership to the Australian New Zealand Orthopaedic Nurses Association, where they quite often nationally will ask one of us to sit on committees, etc. I was invited to sit on the Australian Commission on Safety and Quality in Healthcare Clinical Care Standards group. And this group was looking specifically at developing clinical care standards for osteoarthritis of the knee. And they were finally released in May 2017. So that gave me an opportunity to network with lots of senior colleagues around the nation, as well as there were consumer advisors on there as well. So it was a very fulfilling experience, I'll have to say. So what did it feel like to be an MP in the beginning? Well, I felt like I was the cat amongst the dogs. But now I think, having done this role for going on almost 10 years now, I feel like I'm definitely part of the team, and we all work together and do teamwork exceptionally well. Thank you.